everyone. We'd like to get started on time so that we're not late for the luncheon, and we want to get in as much of this great conversation as we can. Good morning. Great to see all of you out here, and great to have this wonderful panel up here of heart specialists. I think all of you know by now that heart disease is the #1 killer of women in this country. About 500,000 women die every year. That's one every minute, and yet it's known as the silent killer. So before we get into it, I want to introduce our panel. They played musical chairs with me here, so they were trying to test to see if I can identify who's who. But we're going to start to my right here with Dr. McLaughlin, who I've known for a few years, who invited me to participate, so thank you. Great to see you. Then to her right, we have Dr. Jill Kalman. Great to see you. To her right, Roxana Mehran. And then we have Dr. Lori Croft at the end. We're waiting for one more. I don't know if she's in procedure right now, but Dr. Anu Kinney will be joining us hopefully shortly. So I wanted to start by, this is a very timely conversation because I was just at the Glamour Women of the Year Awards Monday night. And the honoree, one of the honoree, the Lifetime Achievement honoree, was none other than Barbra Streisand. And not one to be humble about many things. She stood up and said that her entire life she'd grown up wanting to see her name up on a podium, up in the bright lights, box office hit movies, what have you. And she said nothing gave her more pleasure than recently seeing her name at the Cedars-Sinai Women's Health Center. Barbra Streisand Cedars-Sinai Women's Health Center, obviously a different hospital, but the same premise. And she said she's fighting for gender equality in the treatment of heart disease in this country. So I wanted to start with you, Marianne, and speak to that. Speak about the fact that there seems to be more focus and more research as far as heart disease when it comes to men than there is for women.
Right. So up until around 20 years ago, most women were excluded from clinical trials, and Dr. Mehran can tell you more about that, because the investigators were afraid that they were going to get pregnant and have some harm due to new drugs. So the original research we have in cardiology was really based on men. It was middle-aged white men, and we used that and generalized that to what we should do in women. And then the NIH got smart and said, we can't do that anymore. You really have to include women in trials. Otherwise, we won't know if the treatments are appropriate. So we've come a long way in the last 20 years, but Dr. Mehran can tell you some more details about, she just wrote a great paper about this too.
And can you talk to us about some of the most recent research out there?
So first of all, thank you so much for this incredible opportunity to speak to everyone about gender equality, especially in clinical trials. This is really a pet peeve of mine, something I've devoted the last 20 years in clinical research in. And one of the things that we are finding even up to now, even up to like yesterday when I was at the FDA, that women continue to be underrepresented in clinical trials. Devices and drugs are approved in the United States and abroad based on most of the data on the male population. And this is a very, very huge effort in getting women to be, we don't understand why women are not included. Maybe they're too sick by the time they present, so they get excluded because of their exclusion criteria. They're also a little bit nervous about being part of the trial because they don't know how to handle a lot of the lower socioeconomic status women, don't have the chance to come back for their follow-up and all those things that they need to take care of other things. So we are really working very, very hard to make sure that before a trial starts, that the investigators promise that a certain number of women would be enrolled in the study so we can make something tangible out of the data for the female population. So this is really a new way to do clinical research.
Yeah, and we're just at the precipice right now with regards to equality. Dr. Kalman, can you talk about some of the risk factors out there and how women, I mean, preventative medicine is spoken about so much when it comes to cancers, as it should be. But when it comes to heart disease, I've spoken with so many women who say they had no idea that they were even at risk. Maybe their cholesterol was slightly raised or elevated, they had someone in the family. But other than that, they found out they had a problem once they had a heart attack. How do we prevent that from being the definitive point?
Well, I think getting the message out there is amongst the most important element, and certainly what Roxana and Marianne have said, that women have been underrepresented. Part of it is because women present late, and they don't know they're at risk. And they may be having symptoms that aren't typical of kind of the man clutching their chest. So they're at risk, they don't know they're at risk, and then when they present, they kind of ignore symptoms, and we've known that for a very long time. But the standard risk factors are similar for men and women, and then there are some special ones for men. So high blood pressure, high cholesterol, and we have some new information just as out of the box yesterday. Diabetes, family history of heart disease is extremely important in terms of knowing what our family members and our parents have had. Smoking, obesity, and then there are some secondary ones, inactivity. For women, there are some particularly issues around pregnancy that give you different types of heart disease. And certainly postmenopausal state is different than men. So those are the risk factors. But it's also extremely important to kind of know that women do present differently. And I think that's a little bit of the scary part.
And I want to pick up on what you just mentioned, the new research out just yesterday that was in, I don't know if you saw the New York Times today and a few other publications about particularly cholesterol drugs and statin guidelines. Can one of you just jump in and explain what's different and what's kind of puzzling given what we thought before
We
this?
probably all want to do this. So I'm just going to start off saying, and I spoke to our cholesterol expert at Sinai yesterday, Don Smith, and he just said, whenever you get something new, take a step back, understand it for a moment. But the biggest change, and I'm going to let everybody else speak also, is that we're looking at who's at risk and how do you treat at risk with cholesterol-lowering medications rather than just numbers, which are both positives and negatives. And for women also, they added a new risk element for stroke, which is very important for women. So
I mean, I think in those I'm actually very excited about the new guidelines because we're too often focused on numbers. And here, I think more women and men will be taking statins actually based on these new guidelines because now we're going to be thinking about the patient rather than their numbers. And I think that in many ways, it's a very, I think it's a definite improvement on the prior guidelines.
These guidelines allow us to treat people that maybe would have met goal, but now we say they're even at higher risk. So we're able to give them statins without feeling like we're over-treating somebody. It gives us a leeway to be a doctor and to look at the patient as a whole, and women in particular, if they're at increased risk and their cholesterol is fine, we now have the guidelines that say it's okay to start to treat these women.
And Dr. Croft, I'm glad that we have you now because you're really an expert in heart issues related to pregnancy and during pregnancy as well. And I know a lot of women, myself included, I came to you and I was first pregnant in my first trimester. Can you talk about how common palpitations are during pregnancies?
So palpitations during pregnancy are very common. When you become pregnant, your cardiac output goes up and your peripheral resistance in your body goes down, and to compensate, your heart actually increases. So if you're healthy and your heart rate is usually 60, by the end of your pregnancy, your heart rate is close to 100, 110. So sometimes women just feel their own heart rate when they become pregnant. Also during pregnancy, sometimes your heart can get a little irritated, and some women develop extra beats, and they're perfectly normal during pregnancy, but it's something that you should bring to the attention of someone so that can be taken care of, or at least known that it's something very benign. So I see a lot of women with palpitations, and most of the time it's just they feel their own heart rate. They're not used to having it be so high, and once in a while it's something different, and we're able to treat that. And there are, should you get pregnant, there are drugs that are safe during pregnancy or that we use during pregnancy, so we are able to treat women.
And here we have Dr. Kinney at the end who came in. I want to introduce her to the audience. And you specifically focus on stents and invasive treatments with regards to heart issues and surgeries, but we're becoming increasingly optimistic about minimalizing the invasive process. Can you talk about that?
I mean, just to tell what I do is when patients have blockages, there's various ways of treating the blockages depending on how many blockages are there. Heart, there are 3 arteries, so you could have blockage in 1 artery, 2 arteries, or 3 arteries. And if there are a lot of blockage, ideally we would say they may need open heart surgery. Now the question comes if they have blockage in 1 artery or 2 artery, depending on how tight the blockage is, we can again make a decision. Maybe we can just leave them on medication, which have been discussed. One of them important is statin medication or the cholesterol lowering medication. We have done all that, and still patient has symptoms, and when we say symptoms, usually would be some kind of a heaviness in the chest or shortness of breath, or maybe not able to do what they were able to do before. That's when we can do what's a minimally invasive procedure, where we do it either from the groin or through the wrist. We go into the heart and able to open those blockages. So, so far, going through the history, there used to be what is called stent. It's a metal scaffold. We go open it with a balloon, then we leave this metal in the body. This metal comes with some kind of medication in that metal, so that reblockage does not come back. But what is important is this is where people get a problem that, oh, the stent has medication, that means I should not take any medication. That's a wrong notion that people go home with. Yes, you have a stent, but you still need to take medication to prevent reblockage and to prevent further blockage that comes to you. So first and foremost is lifestyle modification is very important. That's the key, whatever they're doing, stop smoking, healthy diet, take medication, and then regular follow-up with the patient so that whatever work we have done will stay for lifelong. Just to go further with that, we have a newer kind of a stent that is still under trial. What we call is a dissolvable stent, and a lot of news on that. Normally, like I said, this metal scaffold will stay in the body. It will stay for the rest of the patient's life. So what dissolvable stent has is a special kind of a plastic material along with the medication. You place it, and later on, after about 2 years, it starts dissolving. So by the end of 3 years, it's like nothing was done to the artery. Goes back to the original physiology of the vessel, and that's where we are with the new stent that's coming out, will be coming out, but right now it's under trial.
Well, and I know something that a lot of women grapple with is the fact that they clearly have heart issues, but they don't know what's going to be more damaging, the actual procedure and the surgery, or addressing the issue at hand. Who's eligible now for these minimally or more minimally invasive aortic heart valve replacements?
We finished with the arteries of artery blockage. Heart is like a pump. There are two important things. There are arteries, and other one what is like a valve. It's what we call is, if you think about plumbing, the blood flows through a pipe. Whenever it goes forward, we have to make sure it doesn't come back. So there are valves that prevent these things. And one of the important valve is aortic valve. The main artery that comes out of the heart is called aorta, and right where it comes out, we have a valve called as aortic valve. And it's there's a incidence that as you get older, that can get blocked. And that is where we are talking about what is the treatment for that. All these years, the treatment in the guideline also is to have open heart surgery and replace that valve with a newer kind of a valve. In the last 5 years, what has been happening is instead of having open heart surgery, we can do the similar valve through various routes, either from the groin or since it's a valve is bigger, it's not like having a stent where you can go through a very small catheter and do the stent. To do the valve, you need a bigger catheter. So many times these elderly patients who need this procedure have problem with the arteries also. We may have to go what is called directly either through the subclavian artery or through the aorta, and this procedure can be done. So the procedure right now to be done have to be in patients who are high risk for surgery. So when a patient comes, we will evaluate their risk, and we do a scoring system. And based on the scoring system, we know that they are high risk for surgery. They cannot have the regular open heart surgery, and those are the kind of patients will be eligible for this, what is called as a percutaneous
Great
valve.
news for so many people, especially for the elderly out there. My grandmother had this procedure 5 years ago, and it was quite traumatic to see her recovery after the trauma caused by the open heart surgery. I want to turn to you, Dr. McLaughlin, because as far as we talk about statins, preventative care, does vitamin D, we hear about vitamin D a lot, does that work?
So I'll tell you, throughout the history of research in cardiology, every few years we'll say, take vitamin E, take folic acid, don't take vitamin E, don't take folic acid. It goes back and forth. The number one thing you all have to remember is that what you get from natural foods is most important. So getting your calcium from food products is much more important than taking pills. And we know that even from vitamin E, get it from your natural blueberries and strawberries, we know, reduce the risk of heart disease in women if you take it more than 2 or 3 times a week. In the big Nurses Health study, instead of taking a vitamin E tablet, you take things that contain antioxidants. Now, when it comes to vitamin D, over the course of the last couple of years, it's been in the news because as a population, it looks like in general our levels are lower than what has been recommended from like 20 years ago. And the theories are that we're not either getting enough sun exposure or we're using a lot of sunscreen. Or sometimes if we're really overweight, we don't absorb vitamin D as well. The people with really dark skin tones may not absorb vitamin D, and those people like me who are very pale don't get enough vitamin D because we cover up too much. So when we looked at that and found, oh my gosh, all these people have low vitamin D, and there's an association with high blood pressure. So that's very interesting. And now actually one of the strongest links is low vitamin D being associated with increased calcifications in the arteries of your heart. So what we know is there are those associations, so that I remember in medical school, we used to look at these x-rays of these older patients and see the arteries, we see calcium going up and down their aortas, the big artery in your chest, and say, that's part of natural aging. We also see it in people who are in dialysis. They get calcium throughout their vessels. And we thought, oh, that's just normal for if you have end-stage renal disease. But now we know maybe we can prevent that. Maybe there's an association between the vitamin D and calcium metabolism that may be involved with the calcification of some of those arteries. So the news I would say to everyone is you should have your vitamin D checked. Now, the caveat is there's no data yet to say that replacing it will prevent any events. So that's where we are in the research. Dr. Foudy, who's at the Brigham at Harvard, is doing a very large study right now looking at this issue and replacing vitamin D in a large population of people with a lot of women in the study. So we'll have an idea. In my office, she thinks, Dr. Foudy will say that a level over 30 is considered normal. The FDA will say over 20 is normal. So that was a big New York Times article. I still go for the 30 based on her data and looking at the prior data. The question then is, if someone comes in and their vitamin D is 10, I am going to suggest they supplement. We know that vitamin D has other benefits, right? It reduces bone aches and pains. And people have hair loss, it improves hair loss. Repleting vitamin D may have some effect on the immune system. So there are some other potential benefits except from the cardiac perspective. If someone comes in and their level's 29, I'd say keep getting some sun, keep your intake. It's not in a lot of foods, but it's in some fortified milks or fortified with vitamin D. For children, there are some products that are fortified with vitamin D.
And then again, this goes back to speaking specifically for women than compared to men. And we were talking about the research deficit. What can you tell us broadly about the main differences in heart disease that you see between men and between women?
Well, I think as Jill mentioned, it's the prevalence of heart disease in men and women are different. Women present later. They have some protection with menses, and once they go through menopause, they catch up to the men. But usually we see if the average age of a man presenting with coronary disease is in the 50s, for women it's in the 60s. And so one of the things that does happen that I think is very different is the presentation of the heart disease, and as well as understanding that the arteries of men and women are very, very different. Women have smaller arteries, more calcifications, much more tortuous vessels. And when women have diabetes, this really, really increases their risk of premature coronary disease. We see a whole different pathobiological changes with intravascular imaging in the diabetic patient, diabetic female patient, as opposed to the diabetic male patients. And these are the kinds of things that we have seen over and over again. So there's a lot of, and there are people who have said, well, women are just, we're not just smaller men, but that we are really biologically different and that we should be looked at differently. And now there are a lot of research going on biomarker and pharmacogenetics and genomic studies in better understanding the pathobiological changes in the female population as opposed to males. But these are all, a lot of this is basic and it's still not yet for the public, but to note that we are very different. We should be treated differently with a lot of class and of course,
as if we don't know already how different we are from
So there are a lot of
men.
differences, yes.
But I mean, this goes back to all cancers are not the same, right? And so how frustrating is it for you, Dr. Croft, that we're finally just now acknowledging that all of the research may have just been focused on one broad scale as opposed to individual female and male issues?
I would say that the American Heart Association and the women's section has done a great job of trying to bring this to the public eye and really go right for women and kind of really letting women know that heart disease will kill you. Breast cancer is way ahead of us. Everyone thinks they're going to die of breast cancer, yet you're probably going to die of heart disease. So it's frustrating to us as cardiologists that, you know, that initially everything was geared towards men, and we were just small versions of that. And part of it is also our attitude as women. I haven't been to the doctor in years. I'm too busy to go. I have too much to do. I have to take care of my kids. I have to take care of my husband. So we ignore ourselves. We're our own worst enemy at times, right? We don't, eat proper meals. We don't sit down. We don't rest. We don't get enough, exercise because we're so busy. So, bringing that to light and saying that you really need to take care of yourself now because you will end up with heart disease if you don't. We just think we're invincible and keep going. And so I think part of it is the public perception. And like I said, we're catching up now. And it's also just these talks that tell women, you need to pay attention to these things.
And you talk about taking care of yourself and addressing issues now before they get too late, preventative care. What do you mean by that? And I know you focus on cardiac imaging as well. Can you tell us some of the new innovations with regards to stress tests, echograms?
Well, there are many different types of stress tests. Most of the time, the biggest thing that I think is happening now is we're taking women's symptoms that are very different than men seriously. So, a woman might present to the emergency department and say, I just don't feel right, or I have a pain in my stomach, or, I'm slightly short of breath, and we would be ignored. Now, those symptoms are being taken seriously, and women are being sent for appropriate stress testing, whether it's walking on a treadmill or imaging a heart with an echo machine or getting a nuclear study. There are many different types of imaging, and they're actually very good for women. The technology is advanced where, we can read a stress test as good on a woman as we can on a man. So,
And who would you say, Dr. McLaughlin, is the most at-risk candidate for a heart attack out there? I mean, is it someone with high cholesterol? Is it someone who has a family history? Is it a combination of all three, smoking, weight?
Actually, the more number of risk factors you have, your risk goes up exponentially. So it's true. So all of the ones that Dr. Kelman started mentioning, the traditional ones we always talked about, right? High blood pressure, know your numbers, right? Know what your blood pressure is. It should be, ideal is 120 over 80, right? High blood pressure is 140 over 90. You have to know what your number is, not just have the doctor say it's fine. You have to know what your cholesterol is, right? You have to know, now we know that waist circumference over 35 inches in women is a risk factor for metabolic syndrome or prediabetes. We also know now that people who have autoimmune disorders, which is women are more likely to have autoimmune disorders than men, and those are lupus, rheumatoid arthritis, connective tissue disorders. They also come with an increased risk of heart disease, and whether some of it's the actual inflammatory process that's going on in the body, we think, and sometimes the medications that are taken to treat those disorders actually increase heart disease risk. And depression is another one that we now know that depression is linked to increased risk of heart disease. And the theory is there's a couple of things, right? Originally people would say, well, of course, if you have heart disease, you're going to be depressed. But they did a large study showing that taking normal, healthy people and following them, right? And when they developed depression without having any heart disease, years later, even they had increased risk of having a heart attack. And why is that? It may be something to do with the physiology of the blood clotting and platelets in your blood and the hormones, the lack of serotonin may have a result. It may be that just when you're so sad and not interested in life that you don't take your pills or take care of yourself. There's a combination of reasons, but it's important now that we screen and ask women in our office if they have risk for depression and treat that because it can lead to heart attacks. And one last one that we don't talk about a lot, but in my office I find more and more of is sleep apnea. So sleep apnea is a disorder that is definitely highly linked to sudden death and heart attacks. And you'll be at risk. I ask 6 questions. Number 1 is, do you snore? Does someone tell you snore? Or do they say that they wake you up because you were holding your breath, or you wake up sort of choking? Do you wake up with morning headaches? Have you ever had head or neck surgery? Do you have high blood pressure? Are you overweight? Those are all risk factors. Then you ask about sleepiness. Are you tired during the day? Like you've slept for 6 or 7 hours and you wake up and you're still dragging, you need your coffee, you're really tired all day. Or if you sit in a, I think we're all sleep deprived. Or if you get on the subway train, I've had people say they get on a train or a long car ride and they're not driving, they're asleep. Or they do sleep at the wheel. That's a big one. That's a check. Right? So all of those, right? You have 3 more of those symptoms, you have to be checked out for sleep apnea. So what it means you're not getting enough oxygen when you're sleeping, and your brain is knowing that and sort of halfway wakes you up or rouses you. So your body gets inflamed. It says, this isn't normal, I'm not getting enough oxygen, and so a lot of inflammatory markers are increased, increases your risk of heart attack and sudden deaths. It's very important. That's a risk factor that we don't talk about much, but you have to look into it and get treated.
So I'm not trying to turn this into a comedy show, but hypothetically, how many hours of sleep should a woman get a night?
6.
How many of you get 6? Show of hands.
Not bad.
6 or 7.
Oh,
Six
good.
is not bad.
Okay.
If you said, I think if you said 8, it would be amazing.
Yeah, I mean, at
It would
least
be
6.
amazing.
It's
At
at
least
least
six.
6,
Right.
but 7 is
Never.
better. Yeah.
Never
And-
had 6 hours.
Can we try to go through some of the myths out there, again, because we're just learning more and more research and just public service announcements and what have you, and we're becoming increasingly educated as a society about heart disease pertaining to women. But can you talk about and dispel some of the myths out there that you hear constantly?
That women are more likely just to have chest pain and less likely to have a heart attack or die from a heart attack. That's a myth. Women actually, their 30-day mortality rate after a heart attack is higher than men still. For several reasons. We don't know if it's because they're getting their care. We used to say that women would come to the emergency room on average 6 hours after men. So we always say that time is muscle, so that the longer you wait to treat your heart attack, the more muscle of your heart is at risk for being damaged. Let's see, some other myths?
So that's something I really want to talk about because we've done so much research now on heart attacks. And I ran a very large trial with patients presenting with an acute heart attack. And one of the things we found is regardless of everything that you would correct for, that a woman will present much later than a man to the emergency department or the first medical contact. This is really, really, I think, one of the most important, and the last, just 2 months ago in the New England Journal of Medicine, we have done a lot in reducing what's called the time that the patient comes to the door of the hospital to the time that Dr. Kinney will open the artery. That's the door to balloon time. We've really shrunk that. And we've done everything we can, and the mortality has not plummeted any further because the time that the patient, the woman, especially women, and this is men as well, but especially women will present on an average 45 minutes later than men to a first medical contact with a heart attack.
Just because they think that they just dismiss it, that this will get better, it's not a big deal.
We really would like to know. We think some of it is that, and they'll say, oh, it's not me. I'm, why should I, what have you. But this is a really, really important issue.
Yeah, and I think also it's because women, if they're not having, that's one of the myths. They think if they're not having chest discomfort, then it's not a heart attack. And it really can be exertional fatigability or shortness of breath or sweating or nausea. And so I think women wait, and that is actually a myth. I think the other myths are the fact that if it works in a man and a medication, then it's going to work in a woman. We don't know necessarily the right doses for women, if the medications work the same way. So we really need to prove that with a number of women in trials. And I also, and this is an unfortunate element, what Roxana and Marianne are talking in terms of delay is that sometimes a woman does come in with nonspecific symptoms, but an astute doctor would think that it might be heart and at least start the workup and say it's not, and send that patient home without a cardiac evaluation. And that's been one of the most dangerous things that unfortunately I see. The patients who may have had silent heart attacks, to the doctor in the emergency room doesn't seem to be that. They go home and they come back much worse than they did days later.
I have an anecdote. I'm going to interrupt you. My mother-in-law, who had jaw pain, and she was a smoker, and she was coughing. She took 2 aspirin and went to the emergency room, and they laughed at her, like, why'd you take aspirin? She said, well, I thought maybe I was having a heart problem. And they said no, and luckily they kept her because she had bronchitis, and they did a stress test the next day, and she failed the stress test. Wow. And she had a 95% blockage. So she actually knew more than the emergency room doctor that her jaw pain, because she listened to me.
Right. She has a cardiologist in the family.
Good. Well, she didn't call me that day, though, of course. She called me the week later. But guess what?
Everybody ignores their pains. It's absolutely true. Unfortunately, the same anecdote, a young patient, 45, but a diabetic. She didn't have chest discomfort. She had stomach, what we call the epigastric area, right below the sternum. They thought it was gastric, GI, dyspepsia, reflux, gave her medication for that kind of discomfort, sent her home, and then she had a huge heart attack days later.
That's one of the myths.
So that's the myth. Is
right,
that
young women can
right,
get heart disease.
Right, and especially with diabetes.
Right.
So that, and they say, what are some of the take-home points? First of all, have a doctor who listens to you.
Right.
And that's most important. So, you have something to say with anybody. any men, women, you have something to say, but you need someone who's going to listen and say, so you're not crushing, you're not clutching your chest and this is it. And women really need to, because that's where some of the big areas, and Marianne has, a family member like that, but stayed. So that was
I'm
good.
sure we all have great stories. I had a patient who had 4 molar teeth removed for tooth pain. And what she had was a lesion in the right coronary artery.
Wow.
So we finally diagnosed it after her molars came all out. So this was the kind of, we all have stories, I'm sure. I'm sure we all have
And
stories.
smoking does matter. So that's another thing.
Smoking does matter, yeah.
Any of you that smoke should stop.
Right.
It really,
Black
it's
and
a
white.
great equalizer. If you're premenopausal and you smoke, you're just like an old man.
And any age you smoke, I mean, anytime you stop,
Anytime.
is
Stop.
that much better for, as far as not developing heart disease. So we know, for example, we discussed this earlier, and rightly so, we know to go in when it comes to breast cancer and get our annual mammograms after a certain point. So where do you draw the line between going in, what do you say to your GP when you go for your annual physical? What checklist should you go over with them, whether they bring it up or you address it yourself? Because at what point does a patient go from seeing their GP about some issues and then they come to see you? There's a comment.
Well, yeah, go ahead, Jill.
So certainly you should be discussing with your general doctor what your blood pressure is, what your cholesterol is, if you have diabetes. That's straight off the bat. And then if you're having any symptoms that you think might be related to the chest or exertional, or you're not exercising the same way, then there may be more significant exams other than just an EKG. Part of another story, I had a woman came to me, she went to her GP first, the GP did not suggest, or the internist did not suggest going to a cardiologist, but she really wanted to see one. She's a ballroom dancer, and all of a sudden she wasn't able to dance as much. So she was having exertional symptoms are extremely important. But you need to know from your internist what those common risk factors are, and you should be taking those home with you. And also, is your weight in the right place? And then obviously beyond cardiology is a lot of things to know as well. But then are there any other tests you should be having if you're not feeling well? And those are the things that I try and encourage my patients to advocate for themselves.
So much easier said than done to just listen to your own body, right?
But don't let the doctor say, like someone just said this, that they take your blood pressure and it's fine.
Right.
You don't ever hear that it's fine. I want to know. I want to know. I take the cuff off. I say, it's 126 over 84, and then you know.
Your GP should be taking a good history. They should really be looking
Right.
at
Absolutely.
you as a person, what your risk factors are, what happened during your pregnancies. For instance, gestational diabetes puts you at risk for diabetes. Preeclampsia puts you at risk for high blood pressure and heart disease. They should also be making sure they go over your family history if you know it. If your mother had a heart attack at 50, you need to be aggressively treated. You need to be aggressively seen because you're at risk. So I think that your GP should take a good history, and if you feel like they're not listening, sorry, but I think you should get another GP.
They must know your family
Yeah.
history. They have to know your family. And if they're not asking, you may be at the wrong doctor.
Right, exactly.
And does pregnancy affect your risk of developing heart disease later on in life?
Not a normal pregnancy, no, but there are guidelines for women that look at the same thing about the autoimmune disease, that if you have preeclampsia or if you've had pregnancy-induced hypertension or gestational diabetes, these all put you at increased risk to develop diabetes, heart hypertension, and I think they even included it as a minor risk factor for heart disease. So
There may be something about the vasculature, the people who are prone to getting those at younger ages, that their blood vessels are not reactive as well as they should be, and then they can be at higher risk down the road.
we don't know why people get preeclampsia.
And that's
it's
one of
some
the
kind of
questions-
something
It's still the
We
mystery,
don't know.
right?
That's one
They
of the
think it's-
things that we need research on.
Research on, and maybe those same agents put you at risk to get heart disease later on.
And then there's some things that are a little more weird in terms of pregnancy that I sometimes deal with, which is what we call postpartum cardiomyopathy. So some women after pregnancy can actually have a weakening of the heart muscle and develop heart failure. And that's more dramatic, but it is something particularly akin to pregnancy. And then there's some other strange things with pregnancy where the arteries can actually kind of rip apart and cause a heart attack-like syndrome. So these are much less common, but there are things that people need to be aware of. I do want to say, talking about pregnancy, when Lori said palpitations, I had palpitations during my pregnancy, and if it was going to go on another day, I was going to call Roxana.
So when I was pregnant, I was so short of breath, I echoed myself every day when I came into the hospital. I'm like, I'm dying. I know I have a cardiomyopathy. I know I have a
It's like,
cardiomyopathy.
if you have, so I'm saying, if we have time, we have all trained together as cardiologists. We're friends
For a
very
long time.
But the reality is, if you're having a symptom, you need to tell somebody. And I wouldn't tell these guys. I tell her.
But I mean, I
So-
was in the same position. Actually, I was introduced to Dr. McLaughlin because I speak for a living, and so I was pregnant, and we didn't want to announce it until I was after 3 months, and I'm on air, and I can't breathe, and I'm gasping for air, about to expire, and I finally had to go tell my employer, like, listen, I'm not dying, I'm actually pregnant, and I don't want to announce it yet. But it was frightening because I was a healthy, young 31-year-old, and all of a sudden I had difficulty breathing. And when you do that for a living and you don't want to present yourself as being, out of breath every 2 minutes and a chain smoker on air, then it's something that people have to address.
But
and
you did
luckily,
the right thing and went to the doctor, because
Yeah.
sometimes it can be something as bad as Jill's cardiomyopathy, because that can present why you're pregnant at the end of your pregnancy. Most of the time in the first trimester it's hormonal, in the second trimester it's because you're getting big and you can't take a sigh and you can't expand your lungs, and then usually at the end is you're tired and fatigued and just overweight and everything else.
you're carrying another human being.
And you get sleep apnea when you're pregnant.
Yeah.
So I just wanted to say one thing that I think is really important, that there's been a lot of work now being done amongst clinicians to pay more attention to women. But I really believe the time, and this is what the American Heart Association is doing in this kind of a forum, is really educating the public about their right as women to know what their risk factors are and to seek help when needed and to demand from their physicians to be paid attention to. It's really, really important. We just conducted a study across the United States in 3,500 women going to OBGYN offices for just getting their GYN checkups. And we found that amongst these were GYN offices, and we found that the average age was about 55 years of age. We presented this data. It's hopefully in publication in a major journal. But what we found was that 87% of these women had some risk factor, most of whom did not know that these were important risk factors for heart disease. And a lot of what we found is pregnancy-induced complications, as Dr. Croft just mentioned, and the very strong association with their current risk issues. So what I'm saying is that a lot of it now comes back. We really need to come back to the public, and we're doing a lot of work on the scientific level and on the clinical side level, but I really think that the public really needs to be educated.
And it needs to be ethnically appropriate messages.
right.
There's an incredible significant incidence of hypertension and diabetes in African American women and Hispanic women, and I'm not sure we're actually even reaching those populations appropriately.
And
So-
along socioeconomic lines.
Right, exactly.
as well.
So there needs to be ethnically appropriate messages that we're speaking to, and make sure that that message is getting out everywhere, because we're, in whatever disease state, we are really at fault at not doing that correctly, or not as well as we could be.
And so, I want to leave the floor open for questions. I think we have about 15 minutes, so actually, why don't we do that now? If there are any questions, then we can just button everything up at the end. But I see some hands going up. So yeah, do you want to start with?
So I just wanted to ask one question, which Dr. McLaughlin knows very well where it's coming from. So everything that we've discussed so far has to do with heart attacks, but there are other issues for women that aren't necessarily related to heart attacks that can be pretty serious in terms of cardiac health as well.
Right. So it's on our, hadn't got there. Yes, we did do coronary artery disease is what we're really mainly talking about, but atrial arrhythmias are more common in women than in men, right? And that's another reason we're not entirely sure. There's some theories, but atrial arrhythmias is a big catch bag. So people who come in with a really fast heart rate when they're 20 and they're about to faint, it's called a supraventricular tachycardia. The top part of the heart, the atrium, instead of your own pacemaker pacing on time, a little tissue becomes excitable and starts going really fast. And atrial fibrillation, again, we hear it in the news all the time. It's becoming a much more prevalent condition because as we get older, it's a risk factor with age, it's a risk factor with hypertension, and it also runs in families. So the problem is that we can give medications to control it. We can give blood thinners to prevent strokes, but we can't cure it. And that's one of the problems. We have procedures that help, reduce the risk of it happening, but nothing is yet proven. Anyone else want to talk about?
And then obviously there are issues around muscles, that they could have weak muscles or heart failure, and that can happen when the heart muscle is weakened, or even just in long-standing high blood pressure, we see kind of stiffness of the heart muscle over time that can present with a syndrome of congestive heart failure. There are valve issues. So we talk about coronary disease because it's the most prevalent. It's the one we can actually intervene on in terms of lifestyle modifications the most. So it's from a population standpoint, but you're correct. There are many different categories of things that women do get that, again, you want physicians to be kind of attuned to what you might particularly be at risk for.
And
so.
to do more research into treating
and
those
we
conditions.
touched on valvular heart disease a little bit, but also very important is also what we talked about, hypertension, but there's pulmonary hypertension that's also more prevalent in women, some of the younger women, and that could be either secondary, could be just what's called primary pulmonary hypertension, some problem with the vasculature of the pulmonary arteries, which is on the right side of the heart, very important to both the lung and the right side of the heart function. Or it could be secondary to blood clots going up to the lung or some kind of a lung disease that can then increase the pressures in the pulmonary vasculature. So these are also other, I mean, there's just so much to cover.
Yeah.
And we think the number one killer is, yes, we really do have to make some important impact on reducing the heart attack deaths in women, but certainly these other areas are also extremely important.
And when it comes to treatment, how significant is taking an aspirin a day or beta blockers? Do you find that helps?
So the rules are about aspirin. So there have been lots of studies, mostly in men, that showed men at age 50 take a low-dose aspirin every day and they're effective at preventing heart attacks. In the largest women's study to date on aspirin, it showed in the population of 45 to 75-year-old women, the heart attack prevention really occurred at the 65 and over group. And that's the recommendations that women 65 and over be treated to prevent heart attacks. Interestingly, though, if the women were younger and had risk factors, they were less likely to have a stroke in that age group. So it depends then on an individual basis, like what your risk factors are. If you're smoking and you have diabetes and you're 50 and you're overweight, I'm going to put you on a low-dose aspirin because your risk factors, like the risk of taking a small dose of aspirin is less than the risk of having a heart attack. So, or bleeding. So you weigh the benefit and risk for things like aspirin. So you talk about aspirin and now the cholesterol issue, the statins.
Yeah.
That's the other, sort of big thing. It's going to be out in the press even more and more that they say that around 50% of men in their 50s are going to be recommended to take a statin. The guidelines are going for looking at people from 40 to 75 and assessing their risk. They say around a third of women are going to be, recommended to take a statin medication, even those who don't have a history of heart disease. We've all known all the studies, and this is all based on lots of studies, and showing that if you have a blockage or a stroke or a blockage in your artery in your neck, you will have fewer cardiovascular events if you take a statin medication. So now they're saying when you look at, there's a new risk assessment. We talked about those categories that Dr. Kalman and I went through, hypertension, diabetes. Now they're asking us to look at a new tool that will also incorporate, which is very important to talk to your doctors about now, are two other things. And one is C-reactive protein, which is this marker of inflammation. We've talked about it, and it doesn't clog your arteries, but it's a marker that you're at higher risk of heart disease, even if it's from your rheumatoid arthritis. You might always have a high C-reactive protein, but now we know you're at increased risk for heart attacks, and that is part of the formula. And there's also part of the formula now is something called the coronary calcium score. So it's an imaging test that you can have done. The current recommendations up until the guideline yesterday was that if you were someone at what we call intermediate risk of having a heart attack. So if you're 25 and you're healthy and you don't have much risk, you don't need a scan of your heart. If you're 75 and you already had a blockage, you don't need a scan. If you're 60 and you have somewhat high cholesterol, but you really don't want to take a pill, right? But your father died at age 60 or actually at 45. So you have that as your risk factor, your family history, and now your cholesterol's a little high. What do you do? And that kind of patient in my office, I'll say, okay, let's send you for this test called a coronary calcium score. You lie on the table in the CAT scan. It takes 7 minutes. There's no injection. You come out. The radiation now, these days, is the same as a mammogram, we say at Mount Sinai. And they can look to see whether you've developed any calcification in your arteries of your heart. They add up your score. And if your score is now, from this new guideline, is over 300, you should have to be on a statin because you're having a high risk of a heart attack. If your score is 2, you're like, oh, relief, okay, I haven't done anything. I haven't hardened my arteries. But it may not be that you have what we call a soft plaque that Dr. Kinney's going to open, because you can still have a plaque that hasn't hardened. It's just we know now from this newer test that it is a link to higher risk of heart attacks. So that's sort of one of the newer things in this new algorithm of who needs a statin. So aspirin is one thing to ask your doctor about, statin's another thing to ask your doctor about.
And just also make sure you talk about side effects, because once you go on medications, you may not feel well. And, so you really need someone to discuss that with going forward. And what the most commons are with statins will be muscle pains, maybe some nausea, some fatigue, headaches, and sometimes just not feeling great, just feeling different. Some people say, I just feel not as well, I feel a little out of it. But the muscle pains and aches and joint pains are the most common. So they are life-saving in the right categories. Patients should be on them, but you got to know what you're getting into and how often your blood tests should be monitored for liver abnormalities and changes in cholesterol. Extremely important to discuss that.
Other questions? Yes, in the back.
Your mother.
Yeah, no, sure. Right, well, I'll tell you, and I'll let Dr. Croft talk about the stress test. Interestingly, the guidelines about when to do stress tests are when you're having symptoms of chest discomfort or change in exercise tolerance, or, this is one I use a lot in my office, if you're completely or fairly inactive and you really want to start a vigorous exercise program, then it's an indication to go do a stress test.
That's really a change
Otherwise,
in EKG.
yeah, if you have an EKG, that's not normal. But it's not like the colonoscopy at age 50 that everyone has to get. The stress test guidelines from the national guidelines, and insurance companies fight with us every
pretty
day.
vague.
Every day.
But checking your blood pressure and checking cholesterol and making sure you don't have diabetes are those
more
things that
important things.
should happen yearly, and they should be when you go to the internist. So you are doing that and that's what you need to know that you're doing. So if you're doing that and they're okay or you know them, that is essentially understanding your risk. But then there's other things.
But I think this is the $65 million question, because this is a very, very huge hot topic of research right now, looking for the vulnerable plaque, the plaque that's about to rupture. Is there some test that we can do that we can know that we are at vulnerability? And it used to be the plaque, the vulnerable plaque theory, and now we're talking about the vulnerable patient. And I think that very different than pap smears or mammograms for detection of cancer and then knowing your risk. In here, you could be doing everything right, and you could still this could still happen. And this is the area of research that everyone is focusing on. A lot of the work that Dr. Kinney is doing in the lab by imaging the arteries, trying to understand what's going on with the different molecules of the cholesterol. Is there something that we can do differently? Modify the plaque? Is that how these statins are working? And that really is a very big topic of research for future outcome. But I think just everything that has been said is your measures of knowing where you're, where you stand.
Can we get one more question? I think there was in a second. No?
For those of us who have daughters who are young women in their 20s, who tend, I think, to think they're somewhat invincible, what's the best guidance and advice we can give them on managing their cardiac health?
Having a daughter who's about to turn 21, exercise, eating healthy, and modulating your weight. And I say that,
smoking.
And no smoking, obviously, but and moderation of certainly of drinking. And I think that the healthy eating, modulating weight, because I think weight is complicated in young women, and the no smoking are extremely important. And then if there's a family history, your kids need to know about it.
You have to start eating fish 3 times a week.
And in fact, research in France just came out about a year ago showing that French women are smoking more and the risk of heart attack is going up. And the one factor that's different is the fact that they're smoking more. So we have to thank Mayor Bloomberg for making us
Well, that's one
smoke-free.
turnaround we really have seen
We
this
really
country
have
make.
seen that here
And
in this
the
country.
war against
And
cigarettes.
exercise.
And I know we're running out of time. Just quickly, I just want to go, if we can go down the panel. And I want to ask you two things as quickly as you can, if you can sum it up. What keeps you up at night? What worries you the most about heart care right now? And what encourages you the most?
What keeps me up is the next day schedule, to take care of the patient. Will I be able to go through it and come back home? Just a joke aside, I think what just Roxana mentioned is my focus of interest is just like, everybody thinks about, what they're going to die from is cancer, but since we know where they're going to die from heart disease, we don't have an answer to anybody here who is that person who's going to die from heart disease. So that's what the research we are going on. So, if something that I have to go home and think, that's what the one thing we have to do. What was the second question?
What encourages you out of all the research?
Yeah, of all the most important thing that encourages me is that I saved a life every day. Taking care of a patient who is having a heart attack, a patient is almost in the deathbed, and here I go open the artery, put a stent, and happy and come out and tell the family that I saved a life is what keeps me going every day.
What keeps me up, besides my children, is the fact, we talked about this, that I see so many patients that other people have ignored their symptoms, or they've said, oh, you have mitral valve prolapse, you're fine, or you don't feel that, and so what keeps me up is that, I see plenty of people, men and women, but mostly women, that their symptoms are ignored, and, I take the time, but I'm hoping other people will take the time to listen to them. And what keeps me encouraged is that sessions like this, where women are being more informed and we're making great strides in research and in imaging technology for women and all these being more equal to men, and that we're not little men.
So what keeps me up at night are my 3 daughters who are about to, and the future for them as it holds, and heart disease in women, really because of those especially because I have 3 daughters. I was up last night, but I think it was a hot flash. I thought I was having a heart attack, and I did chew a couple of aspirin because I wasn't feeling good. But I mean that. I said, I almost called Jill, but then it passed, and I knew it was a hot flash. But no, but really it does. But what I'm really excited about is the fact that finally the US FDA, the Office of Health, Women's Health, and really clinical trialists are paying a huge attention. Yesterday, in a forum of clinical trials transformation initiative that I lead, our entire focus was on making sure that health disparity outcomes becomes a very, very important issue, not just for women, but for the underserved population, for the African American women, for the Hispanic population, and for the patients with chronic kidney disease, diabetes that are underrepresented in trials. And this is really very exciting to see a movement in the country towards this type of research.
What keeps me up at night, I would say women and all patients who ignore their symptoms and don't seek physicians. What also keeps me up is the patient from the day before who I'm worried about, always keeps me up at night. What gives me hope are absolutely meetings like this where we can get the message out. New research, just like the new cholesterol guidelines, which we're going to put into action today. And the fact that we're able to do that, as well as, I would say, health disparities and the changes that we will make in terms of equalizing that care.
So thank you again for being here, Bianna, for us. I think one thing that keeps me up at night is when people come in, there's something we didn't talk about called broken heart syndrome or Takotsubo's cardiomyopathy. Why do women have a likely chance of having this disorder where their heart just gets very, very weak all of a sudden? It looks like a heart attack, and then it gets better. Like, we don't know why it happens more in women. We don't know why women with diabetes have more heart attacks than men with diabetes. Like, what is it exactly about those vessels that we could do differently? Is there a medication that we should give people with arthritis that would actually be helpful for their hearts? Like, those are the things that we still haven't investigated enough in this world. And then what I'm very happy about is that a few years ago, the American Heart Association did a poll of women about what do you think your leading cause of death is, and around 30% thought that it was heart disease, and now it's up to around 60, 70% of women. So we have made inroads in actually educating women that now can answer that question and say, yes, more women are going to die of heart disease than anything else. But honestly, when you ask each woman, are you going to die of a heart attack? They'll say no. So it's still not them, it's all the other women out there. But we're making some roads.
Well, and what encourages me and should encourage all of you here today is that we talk about the gender inequality, but when it comes to Mount Sinai, I just found out that the cardiology unit has more men than women as far as doctors, so that's very encouraging to hear, and I love seeing these 5 friends. We're women. Yes, most women are women. More women than men, yes, the ratio, yes.
Largest ratio of
Yes.
women to
So
men.
that's very encouraging, and I want to thank all of you for coming today and participating into our great panel. Thank you.